The swallowing mechanism itself, which is normally very automatic, once you start to swallow, you can't stop it. It's like a sneeze. And that little pouch can dilate over time and it can trap food. And patients can feel that. Food gets stuck. And it may eventually go down, or they might regurgitate
it back up. Now, I get a little extreme when I talk to my patients. I say, listen, soda is so bad, it's not meant for human consumption. Okay, it's hyperbolic. I get that. Have you ever had a flat soda?
Yeah, not very good.
Why?
Great question. Why?
Why does it taste bad? What I do see a lot of actually nowadays is something called eosinophilic esophagitis.
Yes, I read about it. I know that I have patients who have been diagnosed with it. How do you treat that with steroids, right? They basically drink fluticasone or take oral fluticasone.
Well, that is one of the treatments for it. One of the things we tend to look for patients who have trouble with swallowing, getting food down. And this is one of the ways your body responds to environmental stimuli. But you're right, you have to have a genetic predisposition for eosinophilic esophagitis in general. But patients will develop an overinflammation in the esophagus that can lead to problems with stricture formation, rings, what we call furrowing of the esophagus, where it looks sort of like cardboard. So those things can all happen. And when the food gets into the esophagus, the motility may be affected. So people come in with food sticking. All right. But again, these things can be made worse, we think, by some of the environmental exposures as well. But one of the treatments is with an acid suppressor, like a proton pump inhibitor. And if that's ineffective, we can go to the steroid, which is swallowed fluticasone, which would typically be a spray that people might use for inhalation.
That's Flonase.
Yeah, Flonase.
Basically Flonase, yeah.
And they just spray it and they swallow it, and they do that twice a day for 3 months, and it's about an 85% success rate in getting patients better.
Can you diagnose eosinophilic esophagitis without doing an upper GI endoscopy, or is that required?
It really is required because you need to have biopsies. And what we look for are the actual eosinophil cells. And so we take biopsies in two places. One would be the distal esophagus, and we talk about distal, that's closer to the stomach. So between the esophagus and stomach, gastroesophageal junction, that's where the reflux is more likely to be affected. Okay, and so we take biopsies there and we look for inflammation and whether there's active eosinophils, which is a type of white blood cell in that distal esophagus. And then we compare that to mid-esophageal biopsies and to see, do you still see the eosinophils, or are they removed? Are they gone? And then we look for the level of eosinophils. Is it greater than 15 per high-powered field is what we call it, or is it less than that? So depending upon whether it's significant in the locations, we'll say, yes, you do have eosinophilic esophagitis.
It's interesting. We see eosinophils all the time in the nose and sinus, and our patients with polyps. When you biopsy a polyp, it's almost invariably going to have eosinophils.
So tell us all about the nasal polyps, all those interesting things.
So sinus polyps remain a bit of an enigma for us. I mean, there's a lot more research into why they occur, but it's this inflammatory response, many times of an unknown cause or an unknown source, like other forms of inflammation that people deal with, whether it's eosinophilic esophagitis, certain autoimmune conditions. But yeah, sinus polyps are a certain segment of the patients that we see. They present to us with chronic stuffy nose, congestion, reduced smell and taste is a very common manifestation, or recurring sinus problems. And the sinuses, the polyps tend to grow. They're benign. Vast majority of cases, these are not cancerous or precancerous, but they can fill up the sinus, fill up the nose, and make it sometimes near impossible to breathe through your nose in the really bad cases.
And how do you treat those?
So initially, we're going to treat those with Flonase nasal sprays, a neti pot with a steroid added to it called budesonide, or oral prednisone, which works really well when you take it. But as you know, prednisone has a lot of side effects, and the higher dose you give and the longer you give it, you're going to start to run into higher risks. So prednisone is usually a bridging treatment.
Short-term treatment.
Let's get the symptoms down so you can breathe again in the short term. And then eventually, in many cases, we end up having to do surgery. Now, surgery is meant to debulk or reduce the volume of polyps in the nose and sinus to restore breathing. There's a very high incidence of polyps growing back. So most of our patients who have surgery once will need surgery again at some point in their life. I've seen a patient not need surgery for 10 to 15 years later.
Mm-hmm.
I had one patient that needed surgery 3 months later.
Oh boy, it grew back
that quickly.
Wow.
It looked like I hadn't operated 3 months later, which was a dramatically bad case, really difficult. So what's new on the market or it's available to us now are these biologic treatments that you see advertised all over. So Dupixent is one of the big ones that we use, where they'll have patients go on. Usually after we've done surgery. The polyps, if I have a patient who has a large volume of polyps, the Dupixent has a harder time making them just go away. But if we've done surgery and then we start Dupixent, we can minimize the chance that that patient will need surgery again.
So these are for refractory patients with
Yes.
polyps.
Yeah.
We actually use that for eosinophilic
esophagitis.
Yeah, but again, for the refractory patients.
Right. So the underlying physiology of a lot of these conditions is very similar.
Yeah.
You know, whether it's asthma, reactive airway disease, eosinophilic esophagitis, sinus pathology, and chronic rhinosinusitis and sinus polyps. So Dupixent will work on multiple conditions.
Do you find these are patients who are more likely to have other allergies?
So the incidence of allergy in our polyp patients is actually very low.
Interesting.
It's not typically an allergic problem.
So we do find that in EOE, that a lot of patients may have asthma, okay? They may have rashes, reactions to medications. A lot of times they're red hair and are Irish and I say, okay. And tall people, I don't know, for some reason we see a lot of EOE, but no, that's just a general thing that we see, but anybody, I've seen it in all sorts of people. So it's interesting that sometimes you do have an effect with being more allergic to other things, and sometimes you just don't.
Well, it's interesting as you bring it up. I think I will probably try to be more aware of my patients with these, that I'm seeing them for sinonasal problems, just to ask a few questions about their swallowing and make sure that if they are having issues, that we can put that on the radar of things to be looked at.
One of the things we find when we're inquiring about, let's just call it EOE, or eosinophilic esophagitis, is patients may have accommodated to it.
And they can live with it.
Well, they don't present with swallowing difficulties, but they don't eat things that are difficult to swallow. And they'll say, well, I have lots of liquids. I have lots of sauces. I'm not going to eat raw vegetables. I'm not going to eat the steak or the chicken. It has to be really well cooked, really well broken down for me, really well chewed. But I don't have any problems, no.
Interesting.
And you say, well, actually, you might. And so those are the patients you want to really ask those probing questions.
Right.
Why do you not eat those things? And I just don't like it. Well, sometimes it gets stuck. Maybe, But yeah, so that's one of the things that we find. It's sometimes the way you ask the questions. Okay. But again, if I get back to harping on all these other things again with smoking and alcohol and marijuana, it makes it worse.
Yes.
Makes it all worse. And if I can get people to stop those things, it really does help. And we haven't even talked about caffeine, but that's something that we can maybe...
I'm sipping on my coffee.
Yeah. Caffeine is interesting. What's your take on caffeine, and does it affect any of the issues that typically come into your office?
Well, I'll confess I like caffeine.
Sure.
I'll have 1 or 2 cups of coffee a day.
Yeah.
But for some people, it can push them over a threshold of having more major symptoms. It usually ties into, the same issues we had just highlighted with reflux activity. Caffeine in and of itself isn't intrinsically harmful directly, but it, reduces the esophageal sphincter pressures, and so it's more likely for things to reflux up. And it dehydrates you, so if people don't drink enough water while they're drinking their caffeine, then they get dehydrated. And it's amazing when people say, well, my mouth feels a little dry, or my throat feels a little dry. It's relative dehydration. They're not dehydrated where they are at risk for anything serious, but they just don't drink enough water.
Yeah.
And so the lubrication that we all need in our bodies to keep things working smoothly.
Doc, I don't like the water. I can never drink water. That's what I hear a lot.
Yeah. So they drink Coke or Diet Coke or carbonated beverages and that has sugar in it and all sorts of other things that aren't necessarily helpful for their diet and their weight and et cetera, et cetera. But
yeah,
it's hard. I probably don't drink enough water
Yeah.
Yes, I should.
Yeah.
It's hard to be deliberate about it. I mean, some people find that they have a thermos that marks how many ounces are in there, and they can track it.
Try to get
day,
through the whole thing throughout the day. Yeah.
You know, it's hard. It's not easy to drink 6 or 8 cups of water a day, whatever the number is. But
it's essential. It's part of every cellular process of the body.
Yep.
And without having the regular, just plain flat water, you're really not giving your body what it needs to be optimally healthy. But you're right. The caffeine, we see that a lot. And all the sorts of beverages people consume that are very tasty.
It's the American diet.
The
Red Bull.
Well, they call it the SAD, right?
Energy drinks.
The SAD, the standard American diet.
Yes.
But no, you're right. It's those things. They make you feel good. They're easy to drink, and they make you crave more of it. And what I told William early on because he always wanted a soda when we go out, I said, well, William, what I want you to do is I'm gonna give you some soda, but I want you to consciously think of what's happening in your brain while you're consuming it. Okay? How do you feel now? I don't know. Give me the soda. I said, all right, take a sip. What do you think? Oh, I like it. Why do you like it? I don't know. Does it make you feel good? Mm-hmm. Yeah, makes you feel good. Would you like some more? Oh, absolutely. Okay, so now you see what the product does. Goes to your brain, makes you feel good, makes you crave more of it, and makes you hungry. Perfect if you're going to sell product.
Mm-hmm. Not
good for you. Because the problem is if you're consuming all those things, you're not consuming the things that you need, and you may be over-consuming significant amount of calories with that. And you ever look at the back of a soda and see how much sugar's in that?
Yeah. So it causes a blood sugar spike, an insulin spike, blood sugar drops, you get hungry, even though you just ate or consumed this product. And then even though your body does not need more calories, you feel hungry again. Or there you go. That's the negative feedback cycle.
Now, I get a little extreme when I talk to my patients. I say, listen, soda is so bad, it's not meant for human consumption. Okay, that's hyperbolic. I get that. But the effect of consuming that regularly creates significant health problems. And we can talk about all the things we talk about, from ENT, from gastroenterology, for weight gain, for diabetes, for heart disease. They're all associated with this. And I remember I had this young lady in the office a couple weeks ago, and she came in with a 12 ounces of with my diet Dr. Pepper or Coca-Cola or whatever. I said, "Did you ever see what's on the back of that?" And I went through this whole explanation of it, and she looked and says, "It's about 60 grams of sugar in there." I said, "Yeah, that's a lot. That's enough for 2 days if you don't have anything else." And she's like, "Are you serious?" I said, "Yes." I said, "Well, think about it this way. Have you ever had a flat soda? Have you ever had a flat soda?"
You mean a non-sugar or
a flat soda with the carbonation, the bubbles have gone away?
Yeah, not very good.
Why?
Great question. Why?
Why does it taste bad?
You have me stumped. What's the answer?
Well, it tastes syrupy, right?
Yeah.
Very syrupy. It's frankly, it's way too sweet. It's disgusting. So then the question is, what was the carbonation doing to that? It was affecting the tongues, the taste buds of the tongue, so you do not interpret the sweetness component of that drink that you're consuming.
It masks it. Yeah.
It masks it. And so when people are consuming the carbonation, it does that for all the food you're eating. It masks how sweet things can be. It blunts it. It blunts that response. But in essence, you're drinking that 12 ounces of soda. It's like drinking a liquid candy bar, which you probably wouldn't want to do. But if you think about it in those terms, it's really sneaky how people can get hooked on the soda. And you think about all these things we've talked about, and that's going on continuously, day after day after day after day. And it's difficult to stop because, again, we have that addiction problem again.
Right. And that's just the soda. That's just what you're drinking.
It's just what you're drinking.
Why don't we add donuts to that?
Yeah.
Or candy bars.
That's right.
Or cookies.
Absolutely. Now, there is a concern with the things you actually chew. You actually have to spend some time to physically break that down, whether it's in your mouth from chewing it or the digestion that occurs from the grinding of your stomach or through your intestines, versus the liquid component, which requires no digestion. It gets absorbed very quickly, almost instantaneously from your tongue. And if you try that, I'd encourage people to just give this a try when they're at home and saying, they have a little piece of candy, and see how quickly it changes how your brain perceives things. But then be conscious of it, because if you're conscious of it, then you can see that's the effect of what I just consumed, and I'm not really hungry. I don't really need to continue to eat.
Mm-hmm.
But it's a very difficult sort of thing to understand. You have to get outside that moment, because, hey, eating can be a very unconscious activity.
Interesting.
Yeah.
Do patients latch onto that, do you think?
Well, I think, when we sit down and we chat, it's one of the things we like to talk about, or I like to talk about with them. Again, just giving them some information. And so if you can be conscious in what you're consuming, that's the first chance to start changing the behavior that's maybe causing these problems that we're seeing downstream that we're trying to treat. That's very difficult.
Yep.
So it's interesting. So with all this kind of stuff, are there other things that you think about from an ENT and GI perspective that really overlap, and sometimes we're not quite sure, does it go to you or does it go to me?
I think we've hit on the major ones. I mean, LPR is the most common swallowing, I think, in our older population.
Mm-hmm.
Is probably the next most common. Many patients I will see in their later decades of life, 70s and 80s, are starting to have some dysphagia for solids and certain foods. And they will be sent to us sometimes initially to see if there's anything wrong neurologically. Maybe they have early Parkinson's disease, and we might detect that with some motility disorders in the throat.
Mm-hmm.
Occasionally it's a tumor or something like that. But I will find that the primary cares tend to have them come to us first.
Mm-hmm.
I'll do my scope exam. We'll check everything out. We'll make sure we don't see any discrete pathology. I may order a barium swallow or a modified barium swallow to see.
What do you think that shows?
So the barium swallow is really just a quick screen to make sure there's nothing more sinister going on.
Like a mass or cancer.
A mass, a lesion.
Yeah.
It might pick up on some motility disorders, a web, a Zenker's diverticulum, something along those lines.
What's a Zenker's diverticulum?
Zenker's diverticulum is a little hernia pouch right below the muscle where the throat, that narrowing we talked about before.
Mm-hmm.
And that little pouch can dilate over time, and it can trap food.
Mm-hmm.
And patients can feel that.
Yeah.
Food gets stuck. And it may eventually go down, or they might regurgitate
it back up. Yeah.
And if it's a large hernia pouch, it would need surgery to close that.
Yeah.
And that would be and that's in our specialty. I don't do that surgery, but some of my colleagues do. Yeah. Where they can either do a laser or a staple to get that out of the way.
Yeah.
So, in swallowing, sometimes it's like everything else as we get older. Sometimes things just don't work as well as they used to. And with, especially if there's other history of a stroke or another neurological condition, swallowing problems can be quite prevalent. A modified barium swallow is a much more detailed look at the actual swallowing mechanism, how a patient manages food in their mouth.
And describe what's the difference between that and a barium swallow.
So a modified barium swallow is just an X-ray that's done with the radiologist. You drink some of the barium, they hold it in the mouth, and then they swallow and they take pictures, and that's about it. A modified barium swallow would be done in conjunction with a speech and language pathologist. They will give you different consistencies of food that are dipped in the barium. So initially it would be a liquid, but then maybe a piece of bread or a cracker or something, and they kind of watch you chew it. How does the patient manage the food in their mouth? Is there any motility problem or coordination problem? And then the swallowing mechanism itself, which is normally very automatic. Once you start to swallow, you can't stop it. It's like a sneeze. A sneeze is coming.
Yeah.
You're hard to stop. But when the swallowing mechanism is initiated, the tongue pushes the food back, and it's supposed to go down in a coordinated fashion through the cricopharyngeus into the esophagus. And if that's not happening, if there's discoordination of those muscular movements, that can be a source of swallowing that is more in the throat. And then, as you know, when it gets into the esophagus, if the motility is not
Mm-hmm.
there properly and the food isn't pushed down in a coordinated way, then patients will feel that. And
Yeah.
that's another type of a swallowing disorder.
Yeah. And it's definitely, there's definitely some overlap here with, we do see the motility disorders, and there's different reasons why they could get it. You may have heard of a condition called achalasia, where the esophagus doesn't move, or it becomes very spastic, but the muscle between the esophagus and the stomach, the lower esophageal sphincter muscle, becomes too tight, or it doesn't relax appropriately. And you end up with a situation where food can just pile in the esophagus and not go into the stomach.
Is there a known cause for that?
Well, we're not sure what causes that. We think it is an acquired condition, so you think, well, it could be a virus or something like that. But it's something that if it's recognized, it can be treated. And one of the things we try to do is prevent esophageal reflux in that situation. Okay, so avoiding acid in the esophagus, because the way the esophagus moves, I like to tell patients, is it doesn't want anything in it. It wants to propulse things through it. Everybody has reflux, as you know. It's just the matter of how much acid is in the esophagus for how long. When the motility is not working well, there's more acid that gets into the esophagus and stays there, and that compounds the problem. So decreasing the amount of acid in the esophagus over time can help. But when you talk about the problem with a condition like achalasia, you really have to relax that muscle between the esophagus and the stomach, and there's different ways to do that. Something that you probably don't do, but this is something that we do. We enjoy it. It's a medication called Botox. And
Oh, yeah.
yeah, so
Botox is used in our specialty for various and assorted, and it can be used in the cricopharyngeus.
Sure.
When that muscle's too tight, but so you're going to use that at the GE junction?
At the GE junction. But it doesn't last forever.
About 3 months, right?
About 3 months.
Yeah.
And I tell patients it's about 3 to 6 months. And after that, we have to make a decision. Do we continue to do the Botox and commit that as you're symptomatic, we bring you back? Or do you have a more permanent solution where they do a myotomy or cut the muscle that is underneath causing that constriction? And there's a procedure that's, I would say it's newer, but it's probably been out for about 15 years at this point.
Mm-hmm.
It's called the POEM, or peroral esophageal myotomy. That just means that you can use an endoscopy scope, go down through there, and cut through the mucous membranes, mucosal membranes, and get to the muscle and make an incision that makes that muscle relax permanently. It used to be right through the chest or through the abdomen. You'd have to go in. So the newer technology for doing that is really superior. It does a really great job for people. But not everybody has to have that. Okay, and some people do well with Botox, and I've had a couple people. Hey, you do the Botox once, and they come back, and it was good for a couple of years. So it depends on the patient, whether they're capable of undergoing additional procedures, or if they have significant comorbidities that would prevent them from doing things in a safe manner. We might commit to Botox. But yes, it can be a very good technique for not only helping somebody, but also making the diagnosis through therapeutic trial. But for us to really get the diagnosis, we have to do a esophageal motility study, which you probably don't do, but we see those. Yeah, we do. This is where you put the catheter in the nose and you swallow it into the stomach, and it's still hanging out the nose, and then you swallow about 10 to 12 times, and we see, is there coordinated movement of the esophagus, or is it discoordinated, meaning not moving appropriately, or going into spasm inappropriately, and does the muscle between the esophagus and the stomach relax appropriately or not? So we can get a lot of information from that, including the food bolus. We talk about when they drink the liquid, the aliquots of liquid, we can actually visually see that going down. Does it go down all the way? Does it get stuck? Or does part of it remain after the swallow is completed? And so those are all the things that we can find from that, and it can help us either rule in or rule out a problem and really determine the next best step for the patient, whether it is Botox, whether it is surgery, or whether it's something else that we could do to help them. But that's an interesting study that I do, and I enjoy doing those. I've been doing those for years.
How frequently do you place a pH probe?
That's interesting. The pH probes, this is, if you go by the brand name, they call it the Bravo, the BRAVO, and that's a wireless pH catheter that you insert into the distal esophagus with a pin through an upper endoscopy. And that's something that can measure the acid in the distal esophagus over 48 to 72 hours with the newer probes. And you can actually see, do you get significant acid reflux, and when does it occur?
Can you put it higher up? Because that's always one of the challenges that we have. We're trying to determine, is there acid exposure here?
Yeah.
Some ENT practices do it, not
Mhm.
many. My group does not. But I don't find it readily available.
Yeah, we typically don't do them higher up. And I think the reasons for that is we're looking for that esophagus, or the acid in the esophagus in the distal part where we know it's going to be. Now, the other question is with that probe in the esophagus being up higher, I'd probably be a little bit more concerned when it did come off, would somebody regurgitate that back up? But again, we haven't done that before. So it may be something that is done just to see how much acid is coming up. Now, if acid is going to be in the distal esophagus for an extended period of time, it's a good assumption it's going to be in the proximal esophagus as well. So the question would be, how often do you need to make that distinction? And it may be on the very difficult cases,
Right.
but not a frequent requirement for the diagnosis.
Interesting.
Yeah, that's fun stuff. So one of the things I also see, we could talk about that. I think people really come in. These are areas where we can really make an improvement, in people's lives by making these changes. And we have, oh boy, older people that might come in with food boluses in the esophagus.
Oh, if you can make a meaningful improvement in
Yeah.
those symptoms, that will change dramatically their quality of life.
Yeah,
You can only imagine if you have trouble eating food
yeah.
and swallowing food, how uncomfortable that is.
Oh yeah, it's it can be really dramatic. But then the goal is to make sure people can live their lives in a comfortable manner, and again to try to do those things that don't promote the problems that we're trying to fix.
Right.
You get into them again: the smoking, the alcohol, the caffeine, all those kind of things can make some of these problems worse. And trying to eliminate those as much as possible can be helpful. Thanks for spending time with us today on Gut and Grit. Coming up next, they talk about the marginal decade. Have you heard that term before?
You have the go-go years,
Mm-hmm.
the slow-go years, and the no-go years.
Yeah.
So go-go is where we are right now. We can go anywhere, do anything.
Mm-hmm.
Slow-go, getting older, it's arthritis, can't move around as much. And then the no-go where you can't travel anymore. You had a population of immigrants that were unusually healthy and had a very low incidence of cardiovascular disease. What they found was this was a very tight community with very strong social connections. And they identified social connections
Mm-hmm.
as an independent factor for health.
Yeah, no, I agree with that.
The other thing that went into making that dietary change was not just weight or sports, but was also dementia risk.
Mm-hmm.
And so if you just read about what is known, what's the data on things in your diet to help mitigate and reduce the risk of dementia, they're exactly the same as those factors that reduce the risk of cardiovascular disease.
Sure.
Seeing your parents with dementia there's very few things in life that are as motivating as fear.
Yeah.
And I fear dementia.